Hello, welcome to my channel. I'm Dr. Jurabian, radiologist. This is a sonography-radiology training channel. I will present different videos could be benefit for physicians and general population. This is the first video about renal calculi, mostly about urethral stents. In this video, I'm going to speak about urethral stents and I will explain what happened for a migratory renal stent. As I explained in first video, if a stone passes into the ureter, the calculus may lodge in three areas of ureteric narrowing. The first one is uretropelvic junction. The second one is where the ureter crosses the iliac vessels, and the third one is uretero-vesical junction. First one, uretropelvic junction stents. If the stone lodges with its transverse diameter and its longitudinal diameter is along the ureter, causes partial obstruction, and renal excretions would pass to the ureter, as you can see this image. In this situation, because the obstruction is not complete, the patient doesn't have much pain, and the patient may experience intermittent colic pain. We can see mild renal pelvis dilatation by ultrasound. As you can see, this is renal cortex, renal pelvis, the UPJ stone, and this is renal pelvis dilatation. Why obstruction is not complete? Because urinary flow would pass beside the stone. But if the stone lodges with its longitudinal diameter, causes complete UPJ obstruction, and renal excretions could not pass to the ureter. In this situation, because obstruction is complete, the patient may experience severe colic pain. We can see moderate to severe hydronephrosis by ultrasound. Why there is severe hydronephrosis? Because obstruction is complete and urinary flow could not pass to the ureter. Now, ureter stones. What is the clinical presentation of the ureter stones? Usually, calculi in the mid-ureter result in pain radiating anteriorly and caudally, which may mimic appendicitis on the right side and diverticulitis, while pain from distal ureteric calculi radiates to the groin via referred pain from the genitofemoral and iliac nerves. If a stone with large longitudinal diameter and a small transverse diameter enters the ureter and crosses the lumen like this stone and crosses the lumen of the ureter by its length, or enters by length but its transverse diameter is large, in this situation there is severe obstruction and urinary flow would block. The patient will experience severe renal colic pain. When the patient refers for ultrasound, we can see hydronephroureter, and by following the ureter, the stone will be detected. As you can see in this clip, this is hydronephrosis and this is the stone. Another one, hydronephrosis, hydroureter, and the stone. But there are some exceptions. If a stone with large longitudinal diameter and small transverse diameter enters the ureter by its length, in this situation there is no obstruction and urinary flow would pass. Therefore, the patient may experience mild pain and urine analysis shows microscopic hematuria. When the patient refers for ultrasound, may be seen mild renal pelvis dilatation and sometimes may be normal without any finding, like this patient. When the stone comes down, it may lodge where the ureter crosses iliac vessels. At this time, the patient will experience severe renal colic pain. When the patient refers for ultrasound for the second time, we can see severe hydroureter and the stone at the level of the iliac vessel. This is hydroureter, this is the stone, and this is iliac vessels. So there is the important teaching point about ureter stones. When a stone enters into the ureterinal diameter and its transverse diameter is small, like this stone, it may be missed by sonography initially. But after a few days, when the stone lodges where the iliac vessels, we can detect it obviously. And the last one is uretrovesical junction stones. What is the clinical presentation of the UVJ stones? Irritative vomiting symptoms such as dysuria and urinary frequency. Very small diameter of the UVJ, that is 1 to 5 mm, accounts for the large percentage of calculi that lodge within the distal ureter. Approximately 80% of stones smaller than 5 mm will pass spontaneously. Usually, UVJ stones cause hydronephroureter and they can ultrasound simply, like this patient. This is hydroureter, this is the stone, and with acoustic shadowing. This is another example of UVJ stone, a large UVJ stone with twinkling artifact in color Doppler study. There are two practical points about UVJ stones. Very distended bladder may obscure the UVJ stone, and we must do ultrasound again after voiding with semi-full bladder. And the second practical point is if the stone located at the distal ureter near the UVJ in fatty patients, or if there are excessive bubble gases, it may not be detected by ultrasound, and we must do non-enhanced CT in these situations. In conclusion, the clinical presentation and ultrasound findings of migratory renal stones depends on the first one is the position of the stone, that is in uretropelvic junction, ureter, or uretrovesical junction, and the second one